to in the primary care pathway. I've been wanting to do this for a while, so I'm excited to have a chance to do it. I'm going to be talking about weight stigma and discrimination, and how, as internal medicine providers, what we can do to kind of change how we talk about it and start to kind of fight some of that stigma and discrimination within our own practices. So that's good. Okay. So I have no financial disclosures. I did want to sort of do a disclosure around context, because I think in any conversation about sort of stigma and discrimination, lived experience really matters, obviously. And so there's this sort of concept of thin privilege that people talk about a lot. And I think it matters to both say that I move through the world in a smaller sized body. And so that's really shaped sort of my experiences around these topics. And then secondly, that during residency, I've been navigating recovery from an eating disorder. And so that also, I think, really informs where I'm coming from. I've spent a lot of time over the past couple of years sort of in the recovery community, and there's a lot of conversation in that space about breaking down weight stigma, and a lot of criticism about what doctors sort of do wrong or could do differently. But I haven't really seen any of that conversation then reflected back in our own training and curriculum. So this is something that I've been thinking about for a long time, and I am excited to have a chance to present it and explore it with you all. And definitely it's a work in progress, and I'm really interested in getting your thoughts and feedback. So the other sort of framing piece that I wanted to start with, there's this really good New England Journal piece from earlier this month that I thought was a really nice contribution to sort of thoughts about physician burnout and what contributes to it and how we can prevent it. And they put forward this idea that there are sort of three pillars to well-being in practice, and those are autonomy, competence, and relatedness. And I feel like sort of diving into conversations around weight and body with patients is a way to both sort of, as providers, give us autonomy to challenge really harmful paradigms around those things, hopefully to kind of increase our confidence and competence talking about it with patients. And then I think ideally really increases the ways that we can like relate to our patients as human beings. So I think that sometimes sort of taking time to step back and think about some of these things is a way to sort of support our own satisfaction and well-being in our practice. Okay, so objectives for today, we'll do a quick history lesson, in particular thinking about how we came to the idea of BMI as a way of measuring bodies and defining what the normal body is, some specific ways that weight stigma shapes health, why you should maybe screen for eating disorders more than you might think, and then hopefully spend most of the time talking about concrete ways that we could do things differently. So I'm going to start with this sort of historical lens. And so I think the history of sort of how we started to measure bodies on aggregate starts with this gentleman here, Lambert Quetelet. So Lambert was an astronomer from Belgium who was living in the early 1800s. And he was really focused on this idea of basically taking the human body and putting it on a bell curve. And he wanted to know sort of what does the person who's at the very middle of that bell curve look like? And that was kind of his sort of defining question. I think it's important to note that this was like specifically men. So he's looking at white, landowning, mostly middle class, older men in Belgium in the 1830s, so a very specific time. And his big contribution is he figured out that mathematically, if you want to create that bell curve and relate body mass and height, it makes sense to divide the weight by height squared. It has to do with the kind of relative mass of the torso and the legs. And so he made that kind of first formulation and started to sort of put credence to the idea of charting bodies on a graph. That idea then sort of gained a lot of momentum in the early 1900s when life insurance companies started to create big tables of data looking at weight, height, and mortality. So in 1959, Metropolitan Life Insurance Company published data collected over about 20 years from millions of adults, primarily men again, and documented a weight to height ratio for all of these people. And they started to define what sort of the middle of that bell curve was. So took the mean and then looked at 20% above, 20% below, and defined those points as what was over or underweight. And then I think most importantly, they started to define this concept of the ideal weight, and they define that as the ratio of weight to height where mortality was lowest. So again, using that kind of like ideal / normal sort of language to define the weight of a body where they felt like the mortality was lowest. So then 1972 was when the BMI, sort of as we know it today, came into existence. That was thanks to this gentleman here, Ansel Keys. Ansel Keys was a physiologist based at the University of Minnesota who was really interested in sort of the human body, what made up the human body, and how diet affects health. I think he's probably most famous for the Minnesota starvation study, where conscientious objectors volunteered to go on a very severely calorie-restricted diet. And Ansel Keys sort of watched what happened to them and to their bodies. This is one of those studies that will never be replicated because our ethics have changed and we don't really do studies like that anymore. But in this 1972 paper, he brought back what he called the Quetelet Index. So Quetelet, again, was that astronomer from Belgium from 100 years before, and coined it the BMI. And his argument was that this weight to height squared ratio was mathematically more accurate. Again, sort of thinking about how do you plot body mass on a bell curve, thought that was more accurate than the life insurance data, which was using just weight to height. Importantly, again, this paper didn't include women, children, ethnic minorities, or elderly people. So again, quite a small slice of society. And then interestingly, the life insurance tables were still widely used until the early 1990s to sort of define what weights people should be at. And the data, again, was collected between 1930 and 1950. So this sort of increasingly dated data was used to support a lot of decision making. And so then the BMI sort of gained a lot of traction in sort of the mainstream medical community. And in 1995, the WHO published its first BMI classification. So this is sort of as we know things today, which are these 4 categories determined by BMI, defining sort of a normal range, and then underweight, overweight, and starting to use the term obese. Interestingly, the NIH in 1995 actually published its own classification, which was a little bit different. The cutoff between normal and overweight was about 27 instead of 25. And then eventually this was updated, I think it was in 1998. So about 3 years later, it was updated to make the NIH and WHO concordant. So changed that cutoff from 27 to 25. And the effect of that was there's this sort of phenomenon where overnight, something like 27 or 29 million Americans went from being told they had normal bodies to being sort of classified as overweight. And I think there's sort of one way to spin it, which is this is just words, it doesn't really matter, their bodies are the same. But then there's, I think, a different way to spin it, which is that there's this sort of like profound yet arbitrary change that happens where all of a sudden people who were told that they're sort of normal or fine are all of a sudden in this sort of pathologic category. So that's some of the history there. And then in terms of sort of what the current conversation is, I think that right now the preoccupation is around this idea of how does the BMI measure up as a health predictor? And the short answer to that question is I think it's a little bit like a Jackson Pollock painting. There is no simple answer. The sort of 30,000 foot view is that a lot of studies have sort of tried or have worked on showing association. And so there was a study from the New England Journal from a few years ago that showed sort of very big picture, higher BMIs were associated with higher all-cause mortality, specifically in a white population. But there was a lot of press last year. There was data from the PURE study, which is the Prospective Urban Rural Epidemiology Study, which was people in sort of around the globe, so high income, middle income, and low income countries. And they found that there was a trend towards greater survival at a BMI of about 27, so above the range that we currently sort of define as normal. And then all of this sort of masks so much heterogeneity, which is that there's a lot of information showing increased survival for certain conditions at higher BMIs. That's true for heart disease, true for cancer. And then data showing that higher BMIs are protective, especially at older ages. And none of this captures the sort of idea of weight cycling and evidence suggesting that the sort of variation in a person's weight over the course of their lifetime can also be sort of an independent factor in morbidity and mortality. So I think it comes to the question of sort of, is BMI a useful metric for individual patients? And I think there's growing consensus around the idea that it's probably not, that it's maybe something that has some use on a population level, but isn't necessarily predictive or useful for the individual patient. Part of that is because it's not that accurate a measurement of body fat, if that's your goal. There are other ways to do that. So thinking about sort of height to waist ratio or things like that. I think probably more importantly, it's this big oversimplification of all the genetic, environmental, sociopolitical factors that shape bodies and the individual person. And I think all of that is sort of increasingly accepted. But when I was sort of preparing this talk, I found that there was a lot of stuff sort of saying like, yes, it's not very useful for the individual patient, but it's still good information to know, or it's still sort of a useful framework for thinking about things. But I'd argue that I'm not sure that's true. And I think that it really sort of perpetuates this prejudicial terminology, thinking about what the normal or ideal body is. And I think the sort of history that's really rooted in this very sort of racially homogenous, gendered representation of different bodies really matters. And so I'd actually argue that probably we should be moving away from this entirely. So I wanted to start with that kind of background. Before I switch to the next thing, any questions about that or thoughts? Okay, definitely add things to the chat box if they come up. Okay, so now I'm going to switch to talking some about sort of weight stigma, give some data on the sort of how prevalent it may or may not be in physicians, and then how it specifically affects health outcomes. I'll give a caveat. I think that this is starting to shift and starting to change. So some of this data might be a little bit dated, but I think still sort of highly relevant and paints a picture of what's going on sort of within our own community of internal medicine doctors. And the other thing is most of this content comes from a University of Connecticut training on health stigma. So that's where all of the infographics come from, and I've included that at the end in resources if you want to take a look. So big picture, weight stigma is sort of everywhere in our culture and society, and healthcare is not an exception. So in a 2012 study of about 2,000 physicians from all kinds of backgrounds, they found that in general, there was a moderate to strong implicit anti-fat bias when they did sort of implicit testing similar to the Harvard implicit bias test, which people have done for other talks in the past. And this is comparable to the general population. When you think about sort of, and this was independent of gender and the provider's own body size. And so thinking about sort of the difference between explicit and implicit bias, they certainly found that that bias was more likely to be expressed when people were sort of open about thinking that body size was attributed to individual behavior. And so I think that's sort of really getting at some of the harmful stereotypes around being in a larger size body. And so the frustrations that doctors reported were around feeling like their patients were less compliant, less motivated, less disciplined, less trustworthy, more annoying. I thought was a really sort of powerful one. But I think also importantly is that even unintentional implicit bias affected physician behavior. So even when people were like, no, I don't believe any of those harmful stereotypes, the implicit bias there still meant that people might sit farther away, use less eye contact, share less information with their patients, and so really shaped the care that they were providing to people. I think also importantly, this doesn't just change the care that we provide, it changes the way that patients experience these visits. And so in this particular study, they found that almost 70% of women who sort of identified as overweight had experienced bias from doctors and had sort of were well aware of the existence of that bias in the interaction. And there's a lot of data that this stigma harms patients. So thinking specifically about sort of how it influences the way people receive or access healthcare. it probably decreases trust with providers. So this was a 2014 study, and patients who reported feeling stigmatized were 45% less likely to report sort of a high level of trust in their primary care doctor. Patients also reported that it would make them more likely to avoid future doctor appointments, so sort of not going back. And thinking again in sort of a primary care framework, women with a higher body weight are in general less likely to seek routine preventative health services, cancer screenings, and more likely to report a lower quality of care that they're getting, and more likely to cancel or delay appointments. So absolutely affects sort of the care that people are getting and then their likelihood of utilizing care services in the first place. There's also a sort of growing body of research on the way that stigma very directly affects health outcomes, not just through sort of the care that people receive, but really the way it sort of shapes health itself. This was a 2009 study of a large population, 22,000 adults. And in this case, so the perception of weight bias, and this is independent of BMI, of sort of other stressors, amount of social support, other factors, really trying to isolate bias itself and the effect of bias, found that it was associated with more mood disorders, so more depression, anxiety, suicidal ideation, certainly more anxiety disorders, and more substance use. There have also been studies looking at how the experience of discrimination, and I think this has been replicated, obviously, not just in weight discrimination, but in discrimination and prejudice sort of all kinds, changes biomarkers. Increased inflammatory markers, increased cortisol, increased blood pressure. And all of these are in and of themselves then sort of a risk factor for increased morbidity and mortality. So it brings us to the idea that sort of when we're thinking about body size and how that relates to morbidity and mortality, probably at least part of that root cause is from stigma itself. And so that the experience of weight bias and stigma over the course of a person's lifetime affects so many domains of life. So we've talked about healthcare, but it also diminishes income and education, and sort of all kinds of other domains. Oftentimes, people report sort of the most discrimination coming from their immediate family members. All of these things contribute to increasing risk for different diseases, decreasing social support, and then that is sort of the common pathway into increased morbidity and mortality. Any thoughts or questions there? I'll keep going. Switch gears a little bit again to talk about sort of eating disorders and how those relate to this kind of bigger idea of weight stigma. And I think the big point that I want to make is that eating disorders mean a lot of different things and that they can affect people in any size body. Like if you take one thing away, I think that would be sort of the big thing. Just to take a second to sort of say, what are we talking about when we talk about eating disorders? There were a lot of changes between the DSM-4 and the DSM-5. So the sort of big three are anorexia nervosa, bulimia nervosa, and binge eating disorder. But there's this big category called OSFED, or other specified feeding disorders, which sort of encompasses a whole host of things. This includes what's called atypical anorexia. So that's for patients who meet all criteria for anorexia, except for the BMI. And then all kinds of eating disorder symptoms in patients that sort of don't otherwise meet criteria for those three main disorders. And so really it's a very heterogeneous collection of things. And because there's this big category of sort of other disorders that are sort of captured in the DSM-5, but I think often not in our sort of typical conceptualization of what an eating disorder is, leads to a lot of things being missed. And I think that it really matters as internal medicine doctors, it really matters because we're sort of first and foremost diagnosticians. And these are sort of conditions that are often missed or undiagnosed. So there's a survey of patients who had been diagnosed with an eating disorder, and about half of them had been diagnosed first by their primary care provider. So that sort of first point of care is often a really, really important point for identifying patients who are at risk. And then I definitely feel like eating disorders should be sort of in the diagnostic wheelhouse of internists, which I think takes sort of a little bit more training and sensitivity than we sort of typically get at this point. And that's in part because they're common. So the same way that diabetes and hypertension are common, it's probably not sort of as prevalent, but are sort of probably present in a lot of our patients. They tend to be underdiagnosed, especially in patients who are sort of not in our typical stereotypes of who has an eating disorder. They're associated with medical complications. And so we will certainly at some point in our career sort of see those complications. And they also have the highest rate of mortality of any mental health disorder. And then we can unwittingly contribute to them by sort of perpetuating weight stigma in the way that we talk about and interact with patients, which is kind of what I'll go into at the end. I think the sort of tying this into the bigger picture of weight stigma, I think the big thing is that there are a lot of stereotypes in sort of how we think about eating disorders, and that leads to inequality in terms of who gets diagnosed, who gets treated, and who's included in research studies. So this comes from a 2018 study looking at, it was like 1,700 people at 12 colleges across the US. And out of that population, so 1,700 people who were diagnosed with eating disorders, probably not unexpectedly, women were 5 times more likely to be diagnosed than men. They were 1.5 times more likely to get treatment. So even if diagnosed, they were more likely to get treated. White students were nearly twice as likely to be diagnosed as students of color, and then affluent students were more likely to be diagnosed. And so I think they sort of encompass this really well in a quote from the paper where they say, many people assume that eating disorders affect skinny, white, affluent girls. But they found that among college students with eating disorders, just 2% were underweight, most were not affluent, and a sizable portion were male and non-white. I think the 2%, just 2% being underweight is an especially important sort of point to take away, which is that eating disorders come in sort of all shapes and bodies. And if we sort of rely on implicit bias to sort of shape who we think is at risk for an eating disorder, we will miss the vast majority of people. I'm not going to spend much time talking about medical complications because I think if anything gets much face time in our curriculum, this is probably it. If you're interested in learning more, there's a really good book that came out last year called Sick Enough by Jennifer Gaudiani, who's an internal medicine doctor based in Colorado, who specializes in taking care of patients with eating disorders. But I think her big takeaways, and I think sort of like, again, in the context of thinking about weight stigma, is that the medical complications of anorexia and bulimia, so thinking about cardiovascular outcomes, decreased bone density, those kinds of things occur regardless of body weight. So there's this idea of atypical anorexia in the DSM, which again is using BMI as sort of the hinge point there, but the medical complications and the sort of psychological harm and suffering that happens are completely independent of body weight. Binge eating disorder is vastly underdiagnosed. So in the study that I was talking about in the slide before this of college students, anorexia is the rarest, but it was diagnosed in about 73% of the students that they talked to, whereas binge eating disorder, which is the most common, was diagnosed in only 7%. So if we're thinking about what's the thing that we're missing the most, it's probably binge eating disorder. And then finally, she comes down, and we'll sort of go into this more, but she really comes down and says to recommend dieting is to do harm to a patient. And so really says that any sort of restrictive dieting or congratulating a patient's weight loss and sort of normalizing that can potentially cause really major unintentional harm to patients. Okay. So I'm going to spend the rest of the time really focusing on sort of, given all of this sort of historical context and sort of what we know about the prevalence of stigma and its effect on patients, what are things that sort of as internal medicine doctors we can do differently? So I think a big part of this is how do we start to challenge the size and health paradigm and the idea that certain sizes are associated with being healthier. How do we start to challenge that sort of in our practice and how we talk to patients? And I think the first part of that is how do we bring it up to patients in the first place? I think oftentimes we think about sort of weight loss counseling or lifestyle changes sort of being part of our bread and butter of what we talk about with patients. I think the first point is to consider discussing weight reduction only if relevant for medical reasons, which is to say if someone is otherwise sort of living their life totally healthy and not interested in talking about weight reduction, not necessarily something that we sort of need or should bring up. For conditions that probably do have some association, so whether that's diabetes, NASH, think about osteoarthritis a lot is something that we don't have great treatments for, but where some decrease in weight can potentially alleviate a patient's symptoms. Usually a 5 to 10% reduction in weight leads to significant risk reduction. So when you are thinking about counseling patients around these things, I think it's important to know that it's usually just a 5 to 10% reduction that can cause meaningful change. But I'd also argue that it's really important to think about counseling around these things as an intervention that has both benefits and risks. So there's some evidence that says in people with a sort of genetic predisposition towards eating disorders, weight loss can be sort of the initial trigger for that symptomatology. So I think that's something to have in the back of your mind. And then all of the ways that sort of counseling weight loss perpetuates weight stigma, and the ways that we've sort of seen that stigma itself can affect patients and their sort of health outcomes, I think are all potential risks of counseling patients around these things that we have to weigh against sort of what we anticipate to be the benefits of that counseling. And so sort of relatedly, I think we have to be really cautious when talking about both dietary changes and then medication or surgery. I'm not going to talk really about sort of the data behind medication and surgery and its effectiveness, lack of effectiveness, because I think that's sort of a complicated, messy area and often a very personal decision for patients. But with dietary changes specifically, I think it's really important that caloric restriction is rarely effective as a means for weight loss. I think this is like a pretty sort of commonly sort of cited idea that most patients who lose some weight will gain that weight back within a few years. And so caloric restriction often does more harm than good, both psychologically and thinking about sort of patients who are missing major nutrients or sort of then experiencing weight cycling or things like that. So oftentimes there are sort of harms that we aren't necessarily thinking about or capturing that go into these recommendations. And then finally, I think a really important part of this is checking your implicit bias. So I've included the Harvard implicit bias test at the end of this. So if you're interested in taking it, it does have one of the categories that you can choose is weight. I think it's one of those things where being informed about sort of our own level of implicit bias. So you have to be aware of it in order to change it in the first place. Would definitely, if you have some free time and want to explore that, I think that sort of being aware of your own, sort of what's happening in your own decision making is a really powerful tool for thinking about how we can change it. But I think for me, one of the places where I get the most, what's been most difficult and where I sort of have felt stuck is what to do when a patient comes and they bring it up. So when patients say, I really want to lose weight because I want to be healthy. So like, what diet can I do? Or what recommendations do you have? Or can I try medication? And I think this is the space that I've often found the most uncomfortable. So a recommendation that I got from an attending yesterday, which I really liked, was this idea of being really frank and sort of calling out problems with the way that we've constructed weight and health sort of as a problem in the first place. And so just acknowledging like, yeah, you're right. Like every time you come to the doctor's office, we make you get on the scale and are sort of measuring your weight and talking about it. But then you can offer a different framework, which is to say it's possible to be healthy at lots of different weights. And in general, bodies will try to sort of be at the weight which is best or most comfortable for them. And I think sometimes just sort of offering this alternative framework can be sort of empowering and relieving for patients. Not always, but sometimes. And then a way forward is to sort of align with a patient's goals and focus on what matters in their lives the way we do for sort of any other thing. And so whether that means sort of thinking about the kinds of movement that make them feel empowered and bring them joy and sort of focusing on like, how do we help you do those things that make you feel better about yourself? Whether it's sort of focusing on treating depression or anxiety that's sort of contributing to poor self-esteem or things like that. There are all sorts of, I think this is often a really sort of meaty and wonderful area to explore with people. And so you can use that as sort of a doorway into exploring those things. But I think I've encountered with some patients that I'll sort of do a little bit to sort of set a new framework. But you have to remember that, like all of us, they've grown up in us and been sort of conditioned in a society for their whole lives that equate weight and health. And oftentimes that's a really sort of people like really hold that close. And so I think that often it doesn't mean when people sort of are having sort of distress around this or really, really wanting to lose weight, obviously it doesn't mean that everyone has an eating disorder. But I think that should sort of prompt your curiosity and have a low threshold to then explore and screen for eating disorder among patients who are bringing that up or do sort of, even when you sort of change the framework a little bit, can like really, really, really want to sort of pursue weight loss as the objective. The eating disorder screen for primary care, I think, is the easiest to use, and it's been validated in primary care settings with relatively high sensitivity. But if you, just to sort of give you the question so that even if you don't do the full screen, you at least have some sort of vocabulary to talk to patients about it. The questions that they provide are you satisfied with your eating patterns? Do you ever eat in secret? Does your weight affect the way you feel about yourself? Have any members of your family suffered from an eating disorder? And do you currently suffer with, or have you ever suffered in the past from an eating disorder? So I think that these are all just sort of like language that you can think about using in terms of starting to explore these things with patients if you're concerned. And then I think the other big thing is that, as in many things in primary care, you really have to play the long game here. So it might be that in sort of one visit, you won't necessarily be able to sort of totally switch the way people are thinking about health and weight in their bodies, but by sort of creating an environment which on every visit starts to kind of separate the idea of weight and health and starts to normalize sort of the idea that health can happen in all body shapes, and really tries to sort of start targeting some of the stigma and shame around those things, can sort of go a long way in creating an environment which is more sort of welcoming and inclusive and sort of models these conversations. Okay, and then the next part is sort of around challenging stigmatizing language in the medical field. So in the same ways that we, I think, sort of can with patients who identify with a gender or were misgendered at birth, and there's a lot of sort of work around making sure that the language that we use sort of reflects the ways that patients sort of self-identify and really sort of gives credence to that. I think that we can similarly have a lot of power in changing the language that we use around weight and body. So one thing that I'd recommend is avoid listing overweight and obese on the problem list kind of in the first place. There's, I think, within sort of body positive or fat activism communities, there's a lot of talk around really trying to avoid these words in the first place, that obesity especially can often come with a lot of pejorative connotations. Overweight really sort of reinforces this idea of normal and then not normal. And so by sort of not listing these as independent problems, it sort of starts to chip away at the way that we pathologize them. And outside of sort of including them on a problem list, that the sort of broader picture of trying to start to avoid these terms in general can be a way of, again, just sort of chipping away at the idea of the normal body. And another thing is that I think that there's really varied practice around this. But I would probably recommend avoiding describing body size in the physical exam unless truly it's medically relevant. I think that obviously is sort of very much sort of at discretion and a little bit vague, but I think I'll oftentimes see sort of, descriptions of body size or shape that probably aren't relevant or don't sort of change our formulation of the patient or way of sort of conceptualizing them. And so if it's not relevant in the same way that don't necessarily include a rash, if there's no rash, I think that there's a lot of power in sort of taking that out of the language that we use to talk about people. So this is a little bit of a simplified example, but I just wanted to sort of give some sense of what some of these language changes could look like. So I'm going to start with a sentence sort of using language that I feel like I've definitely used in notes, have seen used in other notes. And so Miss S is a 70-year-old morbidly obese woman with a history of diabetes, hyperlipidemia, sleep apnea. You're seeing her in clinic, so she's here for routine follow-up. And in sort of discussing how the visit went and what we talked about, given that she has a BMI greater than 40, we discussed weight loss as an important strategy for improving glycemic control and reducing cardiovascular risk. So I think sort of pretty common bread and butter primary care conversation. An alternative way to potentially sort of formulate your conversation with the patient, and especially thinking about this in sort of the era of open charts and patients being able to sort of read how you're thinking about and formulating the visit, other language to think about using would be taking out morbid obesity. So 70-year-old woman with relevant health problems, so diabetes, hyperlipidemia, sleep apnea, here for follow-up. And then so I think that there can be a lot of opportunity to talk to patients about their own sort of history of food, body, and dieting, sort of understanding what that's looked like and meant to them without necessarily recommending those things. And so in this case, you could say we talked about that, and she's reported she had many years of trying different diets. It was always frustrating and discouraging for her. And then focusing not so much on how do you achieve weight loss for her, but how do you help her sort of do the things that are meaningful and important to her in life. That in this case, for this patient, her goal was being able to walk around the neighborhood with her children. That was a form of movement, which was sort of empowering and brought her joy, and that she hopes to work on incrementally increasing the walks outside as weather improves. So sort of a patient-centered goal, and then some reflection on the specific ways that you can sort of help the patient move towards that goal, which matters more to her. Okay. And then finally, I want to talk a little bit about creating more inclusive office spaces in hospitals. So I think this is something that sort of as residents, we maybe have a little bit less agency in, but I know that I've definitely encountered this a lot, both in my own clinic and definitely on the wards. And I think it's something to definitely sort of be thinking about as you move out of residency into sort of creating your own practices. And I think that there probably is a lot of room for resident autonomy in changing these things in the residents, in the clinics and hospitals where we work now. One thing is to have lobbies that have chairs without arms. And so that's like an easy way to create sort of a first space in the clinic, which is accessible to people in every size body. A huge one is gowns that can fit everybody. And making sure that the patients sort of have the same experience in terms of sort of having the same quality of care where you're doing an exam with a gown if that's what's needed, regardless of body size, and have an appropriate gown. Similarly, I've definitely encountered this, making sure that you have medical equipment in the right size and that that's easily accessible. So including vaginal speculums, scales that have an appropriate range if they're mechanical, blood pressure cuffs, and knowing where these are. I think it can often be a really challenging situation where you sort of are aware that you need to choose medical equipment which is appropriately sized, and you maybe know that it's there somewhere, but like not really sure where they are. And I think that sort of moment of then having to sort of look for things or find them or whatever can oftentimes be really hard and uncomfortable for patients. So I think having these things in the office and knowing where they are is actually a huge low-hanging fruit thing to think about. I think on the inpatient side, knowing how to access bariatric beds, it's pretty easy in our system. There's an order in ORCA that you can do that. I think this is the imaging modalities, I think, is a little tougher. I was hoping to sort of like collate a list of what that meant at different hospitals, but haven't had a chance to do that. I know I had a patient that I took care of in the NICU who needed a CT, and there was a lot of concern about whether or not she would be able to, whether the CT scanner was appropriately sized for her body. And so that led to a major delay in actually getting the imaging. And ultimately it turned out that the scanner was suitable and she was able to get it. But I think knowing sort of what imaging modalities are available, what your alternatives are, if the imaging modalities are not available for that patient, or knowing sort of other hospitals in the area that do have those capabilities, is actually, it's super important. Oh, sorry, I was just looking at Oyinka's question. Yes, I totally agree, Oyinka. I think, so yeah, this is like a huge area that I haven't touched on a huge amount in this part, but the sort of idea that food and dieting definitely has to do with food security, like you're saying, access to healthy food, and those are all issues that intersect with so many other sort of domains of discrimination and stigma and inequality in our society. And I think the sort of specific questions around resources for accessible healthy food is especially challenging. I think definitely leaning on your the sort of interdisciplinary colleagues that are available in clinics is really helpful. So nutritionists, I think, can oftentimes be really helpful for patients, and oftentimes are not necessarily explicitly focused on weight loss, but I think can sometimes be helpful in having the time and energy to really sort of specifically sit with patients and think about sort of what are sort of creative ways that they might be able to think about sort of accessing healthy food. And then I think social workers are especially helpful. But I think it brings up the bigger point that there are these sort of bigger systemic issues and inequality that we don't necessarily have answers or solutions to, but that absolutely play a huge role in perpetuating all of these issues. And so going back to a second to sort of this idea of creating more inclusive spaces in hospitals, I think that there is an argument to be made for not necessarily weighing patients at all. I think the caveat to that would be there are times when I think sort of capturing unintentional weight loss is medically relevant, certainly in patients with heart failure or something like that, where you're sort of monitoring fluid status via weight, that can be helpful. But I think one way to sort of get around that sort of should we be weighing at all question is to normalize the idea of offering blind weights, which is rather than sort of when patients check in, having them step on a scale, seeing the number, maybe commenting on the number, that you sort of to all patients provide the option of stepping onto a scale backwards and say, so some people like to know their weight, some people don't. For all patients, if you prefer to step on the scale backwards and not see the number, that is totally okay. And offering that opportunity and really normalizing that. And then similarly, sort of training staff who are taking weights, since it's probably not you, it's probably someone else in your clinic, the idea of training them to take weights without verbal comments, facial expressions. Again, a lot of that is probably already happening, but in thinking about how we sort of build sort of a generally more inclusive, less stigmatizing environment, that can be a really important one. Okay. So I'm gonna stop there. I have sort of take-home points just to summarize everything, but I'm curious if there are other thoughts or questions.
Mary, this is Anna. Thank you so much for your talk. I decided not to type it in because I'm having a little bit of trouble articulating myself well. But I think one of the things I struggle with is that it feels like in internal medicine in particular, we're treating so many of the downstream effects of lifestyle, like diabetes and hypertension and OSA and all the things that you were mentioning, and often treating them pharmacologically. And I feel like there's not enough emphasis on lifestyle changes. And so how do you balance that with things like avoiding mentioning obesity in a problem list, and like avoiding weighing patients? And I just worry that that sort of leads to more of a sort of pharmacologic only treating downstream effects.
Totally, I think that's a great point. So I think what's like a couple of points. So I think one piece is sort of, I think we often look at weight as our sort of correlate of sort of overall health. And so we end up recommending, when we're thinking about sort of how do we find non-pharmacologic ways to sort of promote patients' health, then we end up, for the most part, talking about that as weight loss. But when I'm sort of thinking about being in the office with a patient and talking to them about those things, I can in good conscience say that dieting will work for them. Like for the most part, it doesn't lead to sort of permanent sustained weight reduction. And oftentimes there's a lot of harm that comes out of sort of the dieting process itself. I think that there is sort of really compelling data around the sort of idea of cardiovascular fitness, or things that I think are harder for us to measure in the office. But when I'm talking to patients about lifestyle change to sort of help with that overall risk reduction, then thinking about ways to increase the amount that they're moving, and again, in a way that sort of feels sustainable and doable, and sort of brings them some amount of joy or happiness. Also sometimes focus there. And when I'm talking about dietary changes, usually focus sort of very specifically on things that the patient is already thinking about or already interested in trying. Because I think there's such like conflicting and information overload, and it's so colored by the things that people have access to, sort of as Ayunka was saying. And so I had a patient the other day who was like specifically motivated and trying to like eat at regular intervals, rather than sort of eating sporadically, and wanting to make it sort of more of a like structured, intentional part of his day. And so that ended up being the thing that we sort of talked about, rather than like a specific sort of dietary change or intervention. I think what's so challenging is that we just don't necessarily have easy, straightforward, harm-free ways to help people make sort of lifestyle change that will prevent things down the road. And then there's also sort of evidence showing that people can have diabetes and hypertension, obviously all those things, in sort of any size body. And so that the lifestyle conversations that we have around those things like should be the same for all patients, and that oftentimes sort of focusing on what those changes sort of look like for the individual patient like really matter. Does that make sense?
Thank you. Yeah, that's really helpful. And I think part of the struggle is what our toolkit is, which is working on an individual level and often prescribing medications, whereas a lot of these issues, as Ayunka mentioned, are more systemic. Like, do you have a safe neighborhood to exercise in? Do you have access to food? And those are just generally things we have less control over. So thank you.
Yeah. And I think just sort of acknowledging the things that we don't have control over, and the like sort of like understandable moral distress that comes out of that, I think is also like a really important piece of this, sort of acknowledging the limitations of what we can do as doctors, and the sort of like bearing witness to the injustices that result as a consequence of that.
This is Alice. I also wanted to just talk instead of type, but there's Mary, I just want to say thank you so much for bringing up this topic. I think it's incredibly important, and I think I agree with you. I think just in general, the medical culture does a lot more harm than good when it comes to talking about weight. And I just wanted to put in a plug for, there's a family medicine doctor who practices at Hull Health called Lisa Erlinger, and she practices what she calls weight neutral healthcare. And her basic tenets, which is a lot of what you already talked about, Mary, but basically is just to provide the same care to patients regardless of their BMI. So if someone is coming in with knee pain from osteoarthritis, the idea is just to treat that person's pain as you would with a person who is this of a smaller body, and to not, because her main focus also is just that, like you said, Mary, dieting, really, there's so little evidence. We have so few proven methods of effective weight loss, and that a lot of the things that we promote can be so harmful. And so really just focusing on, if this person had, their BMI was 24, how would you treat them? And then use that same exact approach with your patient who maybe has a larger body.
That's awesome. Thank you.
Any last burning questions from the group?
Okay, so I'll just kind of quickly recap what we've talked about. The BMI is the standard, very widely accepted measure of body mass and health, but increasingly criticized as inaccurate, oversimplified, and prejudicial. Would think about not using it at all, taking down the posters that might be hanging up in your clinic. The experience of weight stigma increases morbidity and mortality through a host of factors, which include lower quality of healthcare and decreased utilization of healthcare. Primary care docs play an important role in diagnosing eating disorders, which are heterogeneous and vastly underdiagnosed in many communities, especially men, people who identify with a gender other than what they were assigned at birth, and minority communities. And then the psychological harm and medical complications that occur are completely independent of body weight. And internists can be a force for change. So consider the risks that are associated with counseling or recommending weight loss. Model non-stigmatizing language in your conversations with patients and your notes. There are a lot of ways to work on creating size-inclusive healthcare spaces. So if you're interested in more, these are some great resources. The training on weight stigma that I referenced from the University of Connecticut is there. Health at Every Size is oftentimes a framework that's sort of used outside of the medical community to talk about these things. We're taking a look at the Harvard Implicit Bias Test for Weight is also there. And then also just wanted to say, if anyone is like navigating mental health in residency or anything like that, definitely I'm here as like a personal resource for people as well, because I think that's also something that's common and not talked about enough. These are sources, and then any other last questions? Oh, and Reed, yeah, I can send you that. I'd have to take a look back at the data, but I can take a look and send you that.
Thank you so much, Mary. That was really fantastic. I was going to say, why don't we all take a couple-minute break? Let's be back at 10:45. And then Vince is going to be doing another pulmonary talk for us. And in the meantime, if there's any last burning questions, I'm sure Mary is happy to answer them during break time if